Hi, students. This week we're examining changes in health policy in Cuba that led to the implementation of their system of primary health care. In these first weeks of the class, we're focusing on policies related to the provision of primary health care and universal health coverage and primary health care systems that were implemented in two countries um, in Latin America and the Caribbean. So we'll focus on Cuba in this presentation, but I also provide some information on Costa Rica and Rwanda as comparisons, and we'll discuss some of the similarities across these models of primary health care and their challenges, and then focus on the very specific challenges in Cuba. In looking at these four systems, including Brazil, you can see that Cuba implemented a system of primary health care in the 1980s, and this is before many other countries did so. Brazil had a new constitution in 1988, and shortly thereafter focused on the provision of primary health care in that country. Costa Rica implemented a number of health system reforms in 1994, and these included the establishment of primary health care teams called basic integrated healthcare teams that included physician and nurses, as we're going to learn about in Cuba, but also other providers. Rwanda is an example primary healthcare system that was implemented in a lower income country. It was implemented after the genocide in 1994. And in this system, community health workers provide the primary healthcare services in communities and refer patients to other providers as needed. Here we take a look at the country context for Cuba. It's a population about 11 million with some ethnic racial diversity in the country, as you can see on the slide. Nearly 80% of the people live in urban areas. And what's significant about Cuba is that a high percentage of the government budget is spent on education, healthcare, and social welfare. Here you can see that about 12% of the GDP is spent on health. The vast majority of that is spent by in the public sector. Also, a sizable amount of the GDP is spent on education, and education, including university education, is provided at no cost. The GDP in Cuba is comparable to some other countries in Latin America and the Caribbean, with about $9,000 to $10,000. This is pre-COVID per capita. While unemployment is low, poverty is high, even though the government provides services at no cost, such as housing, education, and healthcare. Due to high levels of healthcare access and education, the Human Development Index in Cuba is fairly high. With limited resources, some countries initially focus on a limited number of programs when they're implementing healthcare reforms. For example, they might focus on maternal and child health, infectious disease control, such as tuberculosis, or water and sanitation, in part because there are effective ways to address these issues. They can be fairly low cost and therefore easy to implement and have a sizable impact on the health. However, an alternative model is a primary health care delivery model in which community-based services are integrated. And although the system might have started off providing maternal and child health services and services for infectious diseases, they have now expanded to other types of services, such as the identification and treatment of chronic diseases and addressing environmental issues in the community. Cuba has what we might refer to as a primary healthcare system, with some services receiving designated resources and a specific focus. For example, in Cuba, very strong focus is allocated to the provision of maternal and child health services. Other countries might also have specific resources targeted to certain conditions. For example, low-income countries that receives a sizable amount of resources from donors, either through bilateral agreements with another country or through international organizations, for example, for HIV. And in that case, some of the resources are focused on a specific population with specific reporting. So before we look at health indicators and the health service system in Cuba, let's look at the background. The country was colonialized by the Spanish largely, but the British and the US also had control over the country for some years. In 1959, they had a revolution, and currently the country is considered a socialist country, although there's one political party, the Communist Party. When the new government came into power in the 1960s, they focused on improving access to health services. While some people in urban areas with resources had good access to health care services, persons with lower resources or who lived in rural areas had much lower access before that time. In addition, during this period, due to the change in the government and its practices, many physicians, dentists, nurses who had worked in the private sector left the country. With so many providers leaving the country and a goal to improve access, the government looked towards creating a new system of care. The health policies were formed using data, information from other countries on the successes they had in improving health outcomes, as well as politics in Cuba and abroad. Initial programs included those requiring fewer resources with high impact, countrywide vaccination programs, improved sanitation. They created polyclinics located throughout the country that had physicians with different specialties in clinics to provide a wide array of services, including pediatric, obstetrical, internal med, orthopedic, and other services. However, they found in these polyclinics that the care was not coordinated when a person or a family required multiple types of services, and their caseloads were quite high. In the late 1970s, they started adapting a community medicine approach. And in the polyclinics, they set up primary health care teams that included a few physicians, such as pediatric, obstetrical, and internal medicine providers. And they were responsible for designated populations typically designated by a geographic area. However, they were primarily, again, clinic-based, even though they went into the communities. Recognizing these issues, they conducted assessments to identify some solution. In these primary healthcare teams that were clinic-based, the physicians were still focused on treatment rather than prevention, and use of emergency room services was still high, and costs were high. At the same time, there was a global conference on primary health care held in Alma Ata, and the World Health Organization, the World Assembly, and many countries supported the use of primary health care services that would focus on health education and prevention, community engagement, use a team-based approach, recognize many of the factors associated with poor health, such as social and economic conditions, use intersectorial approaches, recognizing there's needs to address health of children in school, of people who worked either in factories or in agriculture, and support equal access. So Cuba decided to implement a new policy and create a type of medical specialty that called general comprehensive medicine. And the idea was they would train physicians to work in communities, address a wide array of problems resulting in poor health, and then make referrals to polyclinic as specialty care was needed, and coordinate care with the specialty providers. The family doctors that were trained in this specialty lived in communities. The doctors worked with nurses in teams that were responsible for the health of a set number of patients. In order to do this, Cuba made a commitment to increase the number of medical schools in order to train enough physicians to be able to provide physicians who would be community-based, and also to allow students to study in the region where they live. The idea was if people didn't go to large urban cities in other provinces to study medicine, they're more likely to stay and practice in the province or the region where they're from. Students spent more time in medical school on rotations in polyclinic, in consultorios, which were the doctor-nurse offices, and in the community rather than in medical schools and in hospitals to obtain training. And then they were required upon graduation to serve in rural areas. Students obtained a residency in general comprehensive medicine. Those that wanted to go on and do a second specialty, another area of medicine, such as internal medicine or orthopedics, they could go on and do so. So now let's look at the results of this change in policy with regard to how physicians were trained and where they were located. Currently, about 80% of healthcare in Cuba is provided at the community level. That includes hospitals and the polyclinic. The polyclinics are the clinics where the specialists are located, although the specialists go out to the consultorios for visits. They not only include traditional specialists, but also behavioral health specialists such as psychiatrists, psychologists, and social workers, as well as dental providers. And they, in turn, can refer to hospitals and hospital outpatient clinics for more specialized services. The provision of private health services in Cuba is still greatly limited. So what does a consultorio look like? It's different whether someone's living in, working and living in an urban area or a rural area. Here's a picture of the traditional model of a consultorio from a rural area in Cuba. Each family doctor nurse team would be assigned designated number of families to serve. They might have more families in an urban area rather than a rural area. They're asked to provide preventive primary care, risk assessment. That means each person and household is assessed from having non-acute risks, such as maybe needing health education or maybe birth control, to having more acute risks, chronic risks, and more disabling risks. And homes are visited based on the risk level of the home. The doctor and nurse teams are responsible for assessing the environmental needs of their communities. For example, assessing standing water that can put them at risk, for mosquito breeding and conditions spread by mosquitoes such as dengue and chikungunya. They're held accountable for the health of their populations, and that health statistics are compiled. And for example, if women who are pregnant in their communities are starting prenatal care late in their pregnancy, that would be noted. Or for example, if people have a chronic disease like hypertension, are visiting the emergency room what might be considered too frequently, that might be noted. And then the primary care and nurse teams would be questions about how they're providing services for these patients. Similar to many other countries with a more centralized health system, they're structured regionally. Bottom of this chart, you can see a number of family doctor nurse teams are working and organized into basic health teams that are then supervised and can make referrals to polyclinic. The polyclinic to local hospitals at the municipal level, and then more regional hospitals at the provincial level that would have a wide array of specialty services. And then at the national level, there would be specialty care institutes and hospitals for the treatment of fewer patients that have more high risk. At every level, you can see of healthcare, whether it's the municipal level, the provincial level, or the national level at the Ministry of Public Health, the government is involved in understanding and organizing and promoting health. Again, on the left-hand side of the slide, you can see the municipal assembly, the provincial assembly, and then the National Assembly. Look at some health statistics for Cuba. As we talked about earlier, some social determinants of health can influence health outcomes. So in this slide, we look at mean years of schooling, which in this year were listed as 12 years, and the average income. Here it's listed in two ways, and I wanted to note the difference. The gross national income here is listed as the income in 2015 based on US dollars, where the conversion between the Cuban currency and the US is made using an exchange rate. This last column, the gross national income per capita, is based on purchasing power parities. And that means that the government provides housing, education, and healthcare in a basket of goods that households typically might pay for. And they provide some access to low cost food. Currency conversion may not really equate the value that the people live in Cuba have to various assorted services and to meet their needs. So a purchasing power parity can count for the differences in costs of those other services, such as education and health. So you can see in Cuba that is fairly high, where the gross national income per capita was not one of the highest in across the other countries in Latin America and the Caribbean listed below, such as Mexico, Costa Rica, Colombia, and Brazil. Despite that, Cuba has a high life expectancy. Let's look next at some other health outcomes. As noted earlier, Cuba has focused on maternal and child health services. And as you can see in this table, Cuba has lower infant mortality and child mortality, that is, child under 5 mortality. A lower percentage of births are found to have low birth weight. I'm going to skip over breastfeeding, and Cuba has high rates of vaccinations and low percentage of women at reproductive ages with unmet family planning needs. Cuba, however, does not rank very high on breastfeeding during the first year of life, compared again to the other countries in Latin America. Look at infectious disease statistics and some other statistics. Cuba has a notable number of people with HIV/AIDS, and they typically have lower rates of TB and dengue. However, currently Cuba is suffering a dengue outbreak. Cuba is known to have high rates of tobacco use, a tobacco producing country, and for years did not really address prevention of tobacco use. So how does Cuba provide these services? We looked at some data earlier on the percent of its GDP allocated to health. And here you can see this is a different year, but it's left roughly 11-12% of the GDP with low out-of-pocket spending. Again, Cuba in this year, out-of-pocket spending as a percent of total spending was under 10%, where as you go down and look at other countries in Latin America and the Caribbean, you can see that a sizable percentage of healthcare spending is out of pocket by the family, either through paying for healthcare services directly or paying for health insurance or a health insurance program. For example, if we look at Mexico, it's over 40%. Costa Rica is lower, but still sizable. If we look at Colombia, it's 15%, and Brazil is comparable to Costa Rica at 25%. Now look at human resources. As we mentioned, Cuba implemented policies to train physicians, nurses, and dentists. And compared to other countries in this table, Cuba has a high number of physicians, nurses, and dentists per 10,000 population. One question, though, is what level of training do the doctors in Cuba who work in the communities have as compared to physicians trained in other countries? All right, well, let's take a closer look at maternal child health services here. Pregnant women will have a high number of prenatal visits on average, and the vast majority of women start early in their pregnancy receiving care. Nearly all deliveries in hospitals and most with secondary level of services. That would mean having higher level of services for women or newborns who experience complications. They have a very low infant mortality rate. And despite all of these services, the maternal mortality rate in Cuba is approximately 44 per 100,000 births, although per year it's less than 100. And it's been given notice and attention by not only the Cuban government, by other countries um, as they create programs and policies to monitor that and improve the outcomes. As I noted, childhood vaccinations were emphasized in Cuba, and Cuba was one of the first countries to eliminate a number of conditions that are preventable by vaccinations. And here I listed the dates for polio, diphtheria, and measles. With respect to infectious diseases, Cuba has implemented programs with a strong focus on primary health care to have early diagnosis of infectious diseases. With early diagnosis, treatment can be provided. And with HIV and AIDS, people are on medications for as a chronic condition. And for TB, they're on medications for long periods of time. Therefore, support is needed to promote ongoing use of medications, as well as to make sure supplies are in place for people requiring them. And that can be more possible as long as the medications are available with a strong primary healthcare system. And some outcomes related to that, in Cuba, many people with AIDS are living long lifespans. And another indication is that co-infection of TB and HIV is very low, due in part because TB can be treated. And there are virtually no cases of multi-drug resistant TB in Cuba because people are not only getting medications early, they are taking their medications through the complete round that's been prescribed. The system can also promote early diagnosis and treatment of other chronic diseases. Collecting statistics, it's easy to identify outbreaks. Early identification and access to care for behavioral health is important. Having doctors and nurses in the community means when there are disasters such as hurricanes, and Cuba is at high risk for hurricanes, and the doctors and nurses know the community, know who is at risk, people who live alone, live in dwellings that aren't strong, people who might need to be evacuated because they live in low-lying areas that might be flooded. And if they're evacuated, and having a plan for where they'll go and how they'll access the medications they need for chronic conditions. And as part of Cuba's healthcare infrastructure, in order to provide these medications and vaccines that we talked about, and due in part to having an embargo by the United States, Cuba had to develop a way to have access to medications and vaccines, and they developed a strong biotechnology center where they can produce nearly the vast majority of medicines needed for primary care and some specialty care medicines and vaccines. How does this system translate into universal health coverage? Going back to what we addressed in week 1, here I present information on the Universal Health Coverage Index created by the World Health Organization for Cuba. The overall index is 83, which is fairly high for a country with its income level. And when we look at some components, we see some weaknesses in the healthcare system. As noted earlier, the maternal child health index is very high. I was surprised to see the infectious disease control index be at a 77 and not be in the 80s, given their focus of early identification and treatment of people with HIV and TB. That could be due in part to the types of medications that are available, or could be with their economic issues, maybe some lapses in supply of those medications. Cuba ranks lower for non-communicable diseases, and some of that is due to uh, low levels of glycemic control for people with diabetes. That could be due in part to maybe providing access to medications and test strips, right, to understand your blood sugar levels. But it could be maybe older medications or less attention given to lifestyle interventions like diet and exercise. A sizable percentage of that non-communicable disease low score, though, is due to higher levels of smoke. Having a strong primary healthcare system also provides for addressing new challenges and ways of transforming that system. For example, Cuba had a cholera outbreak a number of years ago, and they were able, by using these primary healthcare teams who knew their community, to do active case finding in communities rather than waiting till people came into the clinic and may have already spread the condition and were sicker. Similarly, with COVID, they were able to do active case finding in their communities with the assistance of medical students who also went door to door to help do so quickly and frequently. They were able to develop vaccines to address COVID, and the population was used to public health measures. So it made it easier for them to require masks. For example, right now there is a dengue outbreak in Cuba, and people are used to providers visiting homes and helping people assess standing water in their households and in their yards to remove the breeding grounds for mosquitoes and their risk for dengue. Unfortunately, due to their economy right now in Cuba, they are limited in their ability to spray to limit mosquitoes, and that is having an impact on their ability to control this dengue outbreak more quickly. Having a strong primary healthcare system also provides a foundation for which they then can build on. All right, let's look at two other countries quickly as a comparison to Cuba's model of healthcare. Costa Rica is in Central America, has a GDP that's somewhat higher than that in Cuba, has some ethnic diversity, not as much as some countries like Brazil. And similar to Cuba, Costa Rica has made a sizable investment in health and education in its country, and it too has a fairly high human development index. It's interesting to note that a number of years ago, Costa Rica made a decision not to fund a military and divert those resources to meet the needs of its population in terms of social services such as health and education. In the mid-1990s, Costa Rica initiated its primary healthcare model of establishing basic healthcare teams in communities. These communities included more people than the traditional communities we talked about in Cuba, but then they had higher staffing levels with doctors, nurses, technical assistants that are similar to community health workers, medical clerks, right, to collect data that can be used for evaluation and early identification, as well as pharmacists. And similar to Cuba, these teams are able to provide about 80% of patients' health needs. Similar to Cuba, they can then refer patients to higher levels of health services. For example, the basic health teams work in health areas that are then combined into health regions that then are able to support use of hospital service. As with Cuba, Costa Rica has a system of care in which the medical providers, but largely the community health workers, provide health education and preventive services and risk assessments in the community, at homes, as well as in the clinics. And this graphic shows how lots of care is provided outside of a healthcare clinic. So, what do we know about health statistics in Costa Rica? One that I like to point out is they, like Cuba, have high life expectancies. However, different from the United States, and we've just heard statistics on that, mortality rates in Costa Rica don't vary as much by social economic status as seen in these two graphs below. And social economic status is abbreviated SES. First, we'll look at the mortality of people ages 40 to 64 years. And basically, if social economic status didn't matter, or I'm sorry, if mortality wasn't associated with social economic status, you would see the line go straight across the graph. And we see here the blue data for the US shows that persons at low social economic status here on the left have high rates of mortality. And as social economic status increases, mortality is reduced, and the line is fairly steep. I think of this when I think of the low social economic status of American Indian and Alaska Native peoples in our country. And they have lower life expectancies than people with higher social economic status. However, in Costa Rica, you can see where the line is not flat, social economic status has less of an influence in Costa Rica. People with low social economic status here on the left have somewhat higher mortality than those with higher social economic status on the right. However, the line is not very steep. We see similar trends for those over 65 years of age on the graph on the right. Here we see the line for Costa Rica is fairly straight. And with people over age 65 in the United States having access, most of them, probably about 95% or more, Medicare coverage, you can see that the mortality rates here, the graph is not quite as steep and as different as in Costa Rica. But certainly, social economic status in the United States has a larger effect on mortality than it does in Costa Rica. Okay, here let's look at another outcome, infant mortality. This slide shows infant mortality rates in a number of countries in Latin America, and Costa Rica is here right in the middle with infant mortality rates that are lower than the other countries for both the population of African descent, peoples in Costa Rica who are not of African descent, with the infant mortality rates of 10 and 9 respectively. You can see in other countries going to the left, such as Colombia, the infant mortality rates for both populations are higher, and the difference is much greater. And then you can see in Brazil, the infant mortalities are between the two countries. Okay, let's look at Rwanda, another country that implemented a primary healthcare model throughout its country. It has a much lower GDP per capita, less than $1,000 per year. So there are much fewer resources available to use in its healthcare system. And there's a high percentage of the population that lives below the poverty level. And while the literacy rate is 68%, educational attainment is not what it is in Cuba or Costa Rica. Despite that, the Human Development Index is 0.54, which is at the higher end of low, most likely due in part to the contributions that the health system makes to their quality of life. Similar to Costa Rica and Cuba, there is a regional structure to a healthcare system with the community workers working in the communities to provide healthcare, who then can refer patients as needed to health posts and health centers where there are nurses and physicians, and eventually at the district level to hospitals, and at the national level, patients who have needs will be referred to specialty hospitals. What are the characteristics of the community health workers who are the health workers that patients might first encounter when they need health care? They started off focusing on infectious diseases and maternal and child health care services, and the range of conditions they address have expanded over time. They are largely community volunteers that are compensated for some costs, and resources are allocated to funding pools to help them with the costs they incur. Most recently, in some areas, there are models for compensating for the time they spend providing health care services in their areas. How does the World Health Organization classify Rwanda with respect to providing universal health care coverage? Its score is a 57. Remember, Cuba was higher at an 83. Here we can see some of the components of that. MCH is ranked at 63, which I'm somewhat surprised about that, but it could be that that is due largely in part to poverty and transportation to get to sites for delivering care and for follow-up care. Infectious disease control was similar, but the service capacity and access is much lower. So what are some similarities across these different models of primary health care? They focus on health promotion and prevention, free access to most services, particularly at the primary care level for Costa Rica and Rwanda, not at higher levels of care for Rwanda, use of evidence-based practices, surveillance and health system, and involvement of the communities. Similarly, they all address a number of challenges. How are healthcare personnel trained, supervised, and how do you retain them? And this is particularly an issue in Rwanda, where the community health workers are not paid salaries typically. And this is particularly a problem in Cuba with the economic difficulties Cuba is facing, and the fact that with their economy, it can be beneficial to work in the private sector in Cuba, such as tourism. Access to care or healthcare personnel in urban and rural areas can be challenging. It's hard to perhaps retain healthcare providers in rural areas. And the challenge is to be able to use the available healthcare resources efficiently. So systems always need to adjust to new conditions and new types of services. And care coordination across levels of care can be important for that. The cost of medications, paying healthcare providers, and purchasing equipment continue to increase. And the healthcare systems must adjust to other factors that can either influence the GDP in the country or some new issues such as COVID. So what are some specific challenges to Cuba? There's the privatization of the economy that's occurring. As I mentioned earlier, it could be more beneficial for some healthcare providers to work in the private sector that could be providing services, including services for tourists. There's an aging infrastructure, and so the costs of purchasing new equipment for hospitals and water systems with their current economy can be difficult. There's housing shortages, There's government crackdowns on political protests associated with shortages of food and other supplies. There's the aging of the population. The chronic disease burden has increased with the aging of the population. And one of the most recent challenges has been COVID. While it's a challenge to address COVID, Cuba, as noted earlier, has a public health infrastructure that has helped it dealing with the COVID pandemic. The population is more used to public health initiatives, so it was easier to mandate use of a mask, and there were strong penalties for not wearing a mask in public. With their strong biotechnology sector, they were able to develop vaccines and then implement vaccine programs in the country. And people were used to vaccine programs. However, the impact of COVID that's been devastating for the Cubans has been its influence on tourism, and Cuba relied on tourism for a large percentage of its GDP. So that, combined with the embargo and its own economic conditions, has led to a country that's suffering economically. Having a strong primary healthcare system is an asset to Cuba, but it faces a number of other challenges, both economic and political, in providing services and improving the health of its population.